Well, by now you have all completed the skeletal muscular system and the skin, and now we're going to be moving from that anatomy to the anatomy and some of the physiology of our nervous system. Now, obviously the nervous system controls all. It controls your musculoskeletal system, it controls your smooth muscle, and we're going to be talking about the different divisions of the nervous system, those that we have conscious control over and those things that we have unconscious or no control over in terms of autonomic function. But firstly, if we look at the function of the nervous system, it does aid in converting impulses to nerve messages and transferring them to the brain. Now, your book does discuss action potential and some of the electrochemical physiology of converting those impulses. And as you read through that chapter, hopefully you will reflect upon those issues discussed in Chapter 2 when we talk about ions and electrolytes and how important it is that the human body is maintained in a homeostatic space when it comes to sodium, potassium, calcium levels especially. The nervous system at the CNS level, the central nervous system level, the spinal cord and the brain interprets multiple messages that come in, and then there's an interpretation of those messages, an interaction between multiple axonal transfer of info to dendritic processes to other nerves, bodies, and as we have excitatory and inhibitory messages come upon different parts of the brain, that is how our input is interpreted, and then based on, again, electrochemistry, past patterns of those messages, we will then evaluate the impulses and dispatch responses. The central nervous system is comprised of the brain and the skull, as well as the spinal cord and the vertebral column. If you look at the brain itself, and we will do that in some detail, most of our cognitive capabilities are actually processed in the cortex of the brain. There are impulses, as we will learn about a simple reflex, that come right into the spinal cord of the brain, the spinal cord of the central nervous system, that actually, I use this term loosely, but interpret that message and send back out an immediate response in the form of a reflex. So again, the central nervous system is comprised of the brain and the skull, and also of the spinal cord. The peripheral nervous system consists of cranial nerves, 12 total pairs of cranial nerves, and 31 pair of spinal nerves that arise from the leveled at the intervertebral spaces of the spine or the spinal column. The peripheral nervous system consists of two functional divisions, the somatic or voluntary and the autonomic or involuntary sympathetic, both sympathetic and parasympathetic nervous systems. The sympathetic and parasympathetic part of the autonomic nervous system, also sometimes called the ANS, governs activities that go on automatically or involuntarily, such as your heart, your GI tract, your vessel walls. If we look at the nervous system and the cellular level of the nervous system, I kind of introduced some of these parts in previous lectures, but the body of the neuron itself is the functional unit of the nervous system, and it's made up of three parts. The axon, right here, which is myelinated with a fatty-based or fat-based covering that insulates and allows for something called saltatory conduction. When you walk step by step in short little steps, you can only go so fast if we were taking the action potential throughout the course of this entire length of axon. But if you can jump and jump and jump and jump, like skipping, you can move because of the insulation and these little indurations called the nodes of Ranvier. You can actually move that impulse much quicker along the axon. It's essential that we have this myelin sheath for our axonal impulses to transfer quickly. One of the things we'll discuss upcoming is when that myelin sheath has been eroded secondary to disease. We also have the dendrites and these terminal buttons, which at the end of these we're going to look at a synapse where there is a neurotransmitter that is secreted at the level of the synaptic junction that then will touch either a muscle or another body of another nerve to continue to send messages in interaction between many different nerve bodies. So as we define a synapse, which is a junction for the transmission of nerve impulses, it's found between the end of the axon and the dendritic bulb. And again, sometimes it is from one nerve to another, sometimes it's from like in a neuromuscular junction where we have a dendritic bulb then interacting with a sarcomere, and that's how we have our neuromuscular junction. We have a number of different types of synaptic junctions, some that are inhibitory, some of them are excitatory. There is an animation that you will want to watch on the inhibitory and excitatory synaptic junctions that you'll see there on Blackboard. We have three different types of neurons, by the way, and they include the sensory or afferent, and also the motor or efferent, and we'll also speak to those. Before we get there, though, let's look at a normal nerve with a myelin sheath. These are called lamellae, and what happens in an unfortunate disease called, hopefully you know this one, but it's multiple sclerosis. It also occurs similarly in another disease called Guillain-Barré. When you have exposed fiber, the impulses will not transfer as quickly, and because of this exposed fiber, often there's a tremendous amount of pain associated with multiple sclerosis or MS. I have some personal experience with this particular disease because my sister was diagnosed about 4 years ago. It is a disease that's debilitating over time. It is felt to be autoimmune. You feel that this erosion is actually secondary to the fact that there are actually immune factors created secondary to possible exposure to a disease or a stressor that gets the immune cascade overactive, that then starts to actually attack the myelin sheath. Getting back to the different types of neurons, we have sensory and motor neurons. Sensory would take, for example, a impulse from the tip of the finger, and we will be talking about, and your book does a very good job talking about the different types of receptors. And when we did skin, we mentioned that there are different types of receptors to sense temperature, pain, etc. But the sensory nerve cells will pick these up and transfer the message to the brain, where it will be interpreted, and then there will be efferent or motor nerve cells that will send messages back out from the brain to make an effect or a response. Sensory and afferent neurons conduct impulses towards the spinal cord and brain. Motor or efferent neurons conduct impulses away from the brain out to the muscles and also sometimes to glands. Now, a central neuron is a cell or cells within the central nervous system that might carry impulses to and from the brain. So we also have a lot of messages interacting right within the brain itself from different parts of the brain. It also may distribute different impulses to different portions of the spinal cord. So again, within the brain, it may look like this on microscopic exam. You can see the multiplicity of different neuronal bodies, and then axonal extensions and dendritic processes where there's an interconnect between all of these nerve bundles. Now looking at this, which would be that which we might find in a neuromuscular junction or in some other synaptic connection, we can see what your book describes as the synapse. And there's also, I really do want you to watch the animation on the synapse. It does a very good job of talking about both inhibitory and excitatory synaptic connections. We know that for the connection to occur, we have to have a stimulus that can come back down to the synaptic bulb, that with transition of chemicals, and putting it in simplistic terms, and utilizing the energy source from the mitochondria, there is a release from the vesicles at the end of the synaptic bulb of a variety of different neurotransmitters. Based on the type of neurotransmitter and the receptor site, there will be again, either excitatory or inhibitory response. Now, we have to have availability of neurotransmitters for this to occur. So chemically, they need to be available, they need to be able to be released, as you see here, and you have to be able to bring them into, sometimes through these things called gated channels, into the next synaptic receptive side, whether that, again, be a muscle, a gland, or another nerve. I'm going to take a little pause here right now because I do want to just reflect on your text on this particular topic. And I'll tell you in a second here, we're on page, and I apologize, I'm just getting over a really nasty cold, and therefore I'm coughing in between all of these discussions. But in your text, if you look on components of a synapse, figure 9.9, which is on page 244, you find indeed that there shows this diagram a synaptic knob and an axon terminal, or presynaptic neuron. And by the way, the concept of presynaptic is that which we're going to be releasing the neurotransmitters out. And on the arrival of the action potential, or the electrochemical stimulus, at the synaptic knob, that neurotransmitter molecule is being released from the vesicles in the knob at the cleft, and that space between, as you can see, is called the synaptic cleft. The combining of the neurotransmitter and the receptor molecules in the plasma membrane of this postsynaptic neuron, or target organ, I apologize again, opens these ion channels and thereby initiates impulse conduction. There are a number of different kinds of neurotransmitters I've described, again, on page 245. They include such as norepinephrine, dopamine, serotonin, catecholamines, endorphins, enkephalins, and others. They also talk about Parkinson's disease on page 245, which is obviously, as it says, a chronic nervous disorder resulting in a deficiency of dopamine. So that group associated with this disorder is called Parkinsonism. And as a result of having that deficient neurotransmitter, you wind up with muscle rigidity, trembling of the head and extremities, that forward tilt of the trunk, and a shuffling manner of walking. They mention a number of different actors and other famous people, such as Muhammad Ali, Michael J. Fox, and locally in our school district we have had a principal and a basketball coach, all in their mid-40s, that have come down with Parkinson's. We are fortunate in Grand Rapids to actually have 2 Parkinson's clinics. There's all types of research being done in the treatment of Parkinson's. As I mentioned, there was one breakthrough when they came up with the drug levodopa, or L-dopa, which help to increase the dopamine levels for their availability to make those neural connections more fluid. So again, the synaptic cleft receiving neurotransmitters, and the presynaptic bulb stimulating via release from the vesicles. These neurotransmitters will message the impulse to the next target organ or the next nerve body. Now, nerves versus tracts by definition. A nerve is a cord-like bundle or group of bundles of neurons that are located outside the central nervous system. And tracts are bundles of nerve fibers in the central nervous system. From here, we're actually going to go ahead and introduce some of the divisions of the brain. The most important division of your brain for the sustenance of life is actually found here in the brain stem. It includes the medulla oblongata, the pons, and the midbrain. Medulla, pons. The medulla oblongata, again, it's an enlarged upper extension actually of the spinal cord. If you were to continue this on, this is the top end, if you want to think of that as the spinal cord. It's just inside the cranial cavity above that large foramen magnum. It does consist of gray and white matter. In the medulla, bits of gray matter mix closely and intricately with white matter. And what's really interesting about this is this area is called the reticular formation, or net-like. This is actually the region of allowing messages from here to dissipate and then be sent beyond this reticular system, which actually gives you your awake versus sleep state. The pons in the midbrain also consist of white matter and scattered bits of gray matter. Both your cardiac, respiratory, and vasomotor centers are located in the brainstem. If you were to injure the brainstem, and this is exactly what happens sometimes in severe injury to the brain, I apologize again, you might indeed wind up dying because any additional pressure, and sometimes we use the terminology of herniating the brainstem. And what that means is if you had a lot of intracerebral pressure from an injury, disease, if enough of the pressure pushed onto the brainstem to injure these pathways, you no longer would have a regular heart rate or spontaneous breathing. When we deem someone to be brain dead, what we are deeming is not just cortical death, but an inability for higher function to be able to get through this center. The next area that we're going to look at is actually the cerebellum. And the cerebellum, I always think of it looking like a mini brain, okay, but it really isn't. It's the second largest part of this human brain. Here's the cerebrum. The cerebellum is the second largest part. It's in the occipital lobe. If you remember from the cranial names, this is the occipital region. There's gray matter that composes the outer layer and white matter that composes the inner layer. So where the gray matter is, and then white matter would be in the inner layer. We know that this particular region of the brain is responsible for balance and coordination. It helps us give us fluid, coordinated movements and maintain equilibrium and sustain our normal posture. The next region that is mentioned in your book, and actually if we look at, actually that picture doesn't do a very good job of it either, but the region of the diencephalon here. Diencephalon is a small but important part of the brain located between the midbrain, below the cerebrum above, and consists of the hypothalamus and the thalamus. So this is this region right here, the diencephalon. Okay. The hypothalamus actually is below the thalamus, thalamic region, hypothalamus, below the thalamus. The posterior pituitary gland, and again this is anterior over here, this is posterior right here. So the posterior pituitary gland. The stalk attaches to the underface surface of the brain. It is also the region, in this region, that we find the third ventricle. We're going to be talking about the ventricles when we talk about cerebrospinal fluid flow. Again, if you look at the top of page 248 and compare it to this, you can see indeed that you have, this is the corpus callosum, and beneath that is the thalamus, okay? And beneath that would be the hypothalamus. You also see that if you have to kind of imagine the cranial parts, like you can see on the top of page 248 in this region. Again, you've got the pituitary gland, and you also have, not well defined here, but we have a very small, in the posterior portion of the diencephalon, you have the pineal gland, which will actually be introduced by one of your peers in group. And the pineal gland is the gland that's responsible for the secretion of melatonin and for our ability to stay more awake. So we do have that to discuss also from your small group presentation. I apologize. I want to go back one. All right, the cerebrum. The cerebrum is the largest portion of the brain, and the most outer surface, which is not well defined here, is actually called the cortex of the cerebrum. If you look at the cerebrum, you look at the outer surface, the first features that you actually notice are these ridges and grooves, as it says in your book. The ridges are actually convolutions or gyri. The grooves, the indurations in there, are actually called sulci. The deepest groove, or the deepest grooves are all of the sulci are called fissures, and the largest one is the longitudinal fissure that divides the cerebrum into right and left halves, which again in this sagittal cut you really cannot see, but it's really dividing it already from the two halves. The two halves are actually connected by this corpus callosum or corpus callosum. Now, you have this is anterior again, you have the lobes of the brain of the cerebrum, which include the frontal lobe, the parietal lobe, the temporal lobe right here, and the occipital lobe in this region. There's a thin layer of gray matter called the cerebral cortex, as I mentioned. It's made up of many neuron dendrites and cell bodies, makes up the surface of the cerebrum, and then deeper beyond that is the white matter, which is made up of nerve tracts, as we discussed earlier, and makes up most of the interior of the cerebrum. Inside the white matter, there are little islands of gray matter known as cerebral nuclei or basal ganglia. Those cerebral nuclei and basal ganglia function to produce automatic movements and postures. This is the region where Parkinson's disease is affected. Again, the shaking palsy associated with Parkinson's is where that particular region does not have the neurotransmitter to make the fluid motions. Moving on now, and oh my gosh, I am so sorry, you guys. If you indeed look on the page 250, they have more of a colored descriptor of where the frontal lobe is located, the parietal lobe, the occipital and temporal lobe. Very importantly, as you look at that particular picture on page 250, before we get into the meninges, you need to become familiar with and make yourself flashcards or whatever it's going to take to become associated with the associated functions on part B of page 250. This is kind of a memorization game. You want to start to learn that indeed the premotor area of the frontal lobe is responsible for muscle coordination. The prefrontal association area is that area that is responsible for conscious thought and also personality. The Broca area is the area that is responsible for motor speech, which means our ability to verbalize and speak. The auditory association area is that area that allows us to take in auditory messages and interpret them along with the primary auditory area. Posterior to that primary auditory area, if you continue to look on page 250, you see indeed that we have the Wernicke area or sensory speech areas that allow us to interpret the messages that we're hearing and then be able to start to generate messages that will give us our verbalizations. In the posterior region of the occipital lobe is the visual cortex and the visual association area. Located in the parietal lobe, you have the primary somatic sensory area, and also kind of in the inferior aspect of that lobe, you have the primary taste area. Also, parietal is responsible for somatic sensory or our body sense perception. Now this next picture we're going to discuss now. I apologize, but kind of jumped around there a little bit, but I do want you to look on page 250 and make yourself those flashcards for what lobe is responsible for what, because there will be questions on that on the cumulative final. If you look at this particular picture, it's an awesome picture for multiple different reasons. One of which, it really shows you this cortical area of the brain. We mentioned that that was really where the gray matter was, and more interior to that was the white matter, albeit that there were some islands of gray that will also be found more inferiorly. But as we look at this, this is the cranium. And as you guys just learned in the previous chapter, you have both periosteum, which is the very outer layer of that bone. You have a small amount of spongy bone. Okay. And then you have another periosteal layer, so the spongy bone is kind of wrapped around in the periosteum. This is the scalp, obviously with the hair follicles, a small amount of skin. Now beneath this bone and the periosteum, the next layer beneath this is actually now called the meningeal layer, or one of the many meningeal layers. And when you hear the word, oh, they got meningitis, it's because this particular lining becomes infected. Now the dura mater is combined the periosteal layer with the meningeal layer together and make the dura. It's quite tough if you were actually to feel this, and when we actually dissect it off the brain, it's a really very tough amount of tissue. Now below that dura is this subdural space. Right below the dura is the subdural space. So if you ever hear the expression, oh my gosh, they have a subdural hemorrhage, this is an area that they're reflecting upon, where you could have some bleeding post-trauma. Now the next layer after the dura is this little pink line, which is actually called the arachnoid. Now, arachnoid I always think of as spiders, and if you look at this, this is actually something called an arachnoid villus. You see that little kind of extension from the arachnoid. And this little arachnoid villus is that area that is responsible for the reabsorption of the cerebral spinal fluid that bathes all of the meninges. Cerebral spinal fluid is actually produced in the germinal matrix region of the center of the brain. It is secreted into the ventricular system, and then it also connects with the entire covering of the brain along with the spinal cord. So again, this is the arachnoid layer. This is the arachnoid villus. And below that now, if you look in here, this kind of web-like, almost like spider-like, right, kind of web-like area is the subarachnoid space. Beneath that layer is the very thin, very fine, cellophane-like, almost like if you were to feel this, it's a very, very thin lining of the brain called the pia mater, which is right here. Beneath that is cerebral cortex, and beneath that is the white matter. So significant number of layers. I do want you to become familiar with that. I encourage you to actually take time to draw your own version of this, so it gives you a little bit better understanding of the layers. The cerebral spinal fluid is a clear fluid that circulates around the brain. The purpose of having cerebral spinal fluid is a combination of being a shock absorber for the brain, so that when you turn your head side to side, you don't basically get brain damage. It also aids in carrying nutrients and carrying away waste. It is formed in the ventricles, as I mentioned, at the level of the germinal matrix. It is reabsorbed by those arachnoid villi, and it's consistently being reproduced. So it's produced, reabsorbed, produced again, reabsorbed again, and it's essential for the homeostasis, basically, of the nervous system. In your text on page 258 and 259, they do a very good job of another picture very similar to the one I just showed you on figure 921, along with a very good explanation of the circulation pattern of cerebral spinal fluid throughout the ventricles and around the spinal cord. Now, the next step I would like you to take is to go back to that pictorial that I showed you for the lobes of the brain and identify and quiz yourself on the function of the different levels, or what is controlled within the different levels. In addition to that, the next thing I'm going to have you do is to start reviewing the cranial nerves. Cranial nerves are nerves that actually arise right from the brain. There are 12 pairs of cranial nerves. They extend mostly from the brainstem. The fibers conduct impulse between the brain and the structures that they're going to innervate directly. They do not go through the spinal cord. If you look at figure 923, it discusses all the cranial nerves and where their terminal dendritic bulbs are going to innervate. And they are nerves that function for a lot of our senses. The biggest and largest and longest of the cranial nerves is actually the vagal nerve. And that particular nerve, as you can see in figure 923, indeed innervates pulmonic, gut, mid-epigastric regions, and has functions both being stimulated and inhibited that will change heart rate, will change respiratory rate, and more. If you look on page 262, it really does discuss the impulses and where they're coming from, along with the function. So, for example, on cranial nerve number 1, which is the olfactory nerve, which goes from the nose right to the brain, it is responsible for our sense of smell. The optic nerve from the eye to the brain, responsible for vision, is number 2. Number 3 being oculomotor, and that's from the brain to the eye muscles. I've listed here the minimal number of cranial nerves you need to learn, and that was for the purpose of what we call our CARP. In all reality, it is helpful to be familiar with all of the cranial nerves, all 12 of them. Number 4 is actually trochlear nerve, and that's from the brain to the external eye muscles that's responsible for eye movement. The trigeminal nerve, which is number 5, it actually impulses from the skin and mucous membranes of the head and from the teeth to the brain, and also from the brain to the chewing muscles, and its function is to maintain sensation of face, scalp, and teeth and chewing movements. When you get into clinical practice, indeed, you might hear about individuals who have a problem with trigeminal neuralgia. Trigeminal neuralgia is a viral-induced or sometimes hormonal-induced irritation of the trigeminal nerve it's associated with some significant pain, and I've seen many patients with it. Ironically, a number of actually even our post-delivered moms have had difficulties with trigeminal neuralgia. Many of the elderly also suffer from this. Number 6 is the abducens, and this comes from the brain to the external eye movement muscles and is responsible for eye movements. Number 7 is the facial cranial nerve, and it airs from the taste buds of the tongue to the brain and from the brain to face muscles. This one is responsible for your sense of taste and contraction of muscles of facial expression. If you have cranial nerve number 7 and or even trigeminal difficulty with that nerve impulse, you might see drooping of the face similar to somebody being stroked, but doesn't necessarily mean that the original injury is from the central portion of the brain. It may be a nerve difficulty in terms of generating the nerve stimulation for those facial expressions. Number 8 is the vestibulocochlear. This comes from the ear to the brain as well as our sense of balance, and when we talk about the ear, we'll get into a little bit more detail about how that all works. Number 9 is the glossopharyngeal. This comes from the throat and taste buds of the tongue to the brain and from the brain to the throat muscles, and that is the nerve that is very responsible for swallowing movements and our secretion of saliva. The vagal nerve, as I mentioned to you before, is a very long cranial nerve. It comes from the throat, larynx, and organs in thoracic and abdominal cavities to the brain, and also from the brain to the muscles of the throat and to organs in the thoracic and abdominal cavities. Because of its location, this is the nerve that if you stimulate it or overstimulate it, unfortunately, because it has many branches, you can get a lot of side effects of, for example, passing an OG tube or a nasal gastric tube down the throat of an individual. If you stimulate the vagal nerve, unfortunately, some of the innervation of that nerve will actually cause a drop in heart rate because it has a branch that goes to the heart. As it says, sensation of the throat and larynx and of thoracic and abdominal organs, swallowing, voice production, slowing of heartbeat, acceleration of peristalsis. So sometimes when we even pass an OG tube down a pediatric patient or even our little babies, their heart rate will very quickly drop as a result of that nerve being stimulated mechanically from our intervention. Number 11 is the accessory cranial nerve from the brain to certain shoulder and neck muscles, responsible for shoulder movements, turning movements of the head. And number 12 is hypoglossal, from the brain to muscles of the tongue and responsible for our tongue motions. So again, I do want you to look in depth at the cranial nerves. I want you to make some of your own little cheat sheets or whatever it's going to take you to learn what parts of function are located in what parts of the brain, because I will have a few questions on that on the cumulative final. Now, the next section we're going to look at is the spinal cord and the spinal nerves. And this is actually part moving into our peripheral nervous system. If you look again on page 261, it introduces spinal nerves. There are 31 pairs of nerves attached to the spinal cord, and as they mentioned, 8 pairs to the cervical segments, 12 pairs to the thoracic, 5 pairs to the lumbar, and also 5 pairs of spinal nerves attached to the sacrospinal segments, many of which come through those sacral foramen. There's also 1 pair that's attached to the coccyx. So unlike those cranial nerves, they don't have any special names. They're just labeled by where they're located. T8, for example, indicates nerves attached to the 8th segment of the thoracic part of the spinal cord. Now, spinal nerves conduct impulses between the spinal cord and parts of the body, not supplied by cranial nerves. What's really significant about mapping spinal nerve innervations, if you look on page 263, we will be talking about dermatomes. So again, spinal nerves descend from the medulla. They're protected by CSF and the vertebrae. When people have a herniated disc in their back, if some of these, again, this is coming through the vertebral bodies, if any of these nerve bundles or this mixed spinal nerve or their dorsal or ventral roots are in any way pinched, that associates with pain and dysfunction. So if we look at the function of spinal nerves, they are able to generate impulse to distal regions of the body, and excuse me, I am so sorry. Since each nerve emerges from between the vertebrae and one side of the vertebrae, they are able to then be mapped, as mentioned, on dermatomes, to be able to identify what part of the anatomy may or may not be impacted. This becomes especially important when we look at anesthesia. Bear with me for just 1 second, because I do want to jump ahead to this and kind of go back to the other in a second. Looking at the spinal nerves and dermatomes, you can actually see both in your textbook as well as in this pictorial. If I was an anesthesiologist and I wanted to give some anesthesia, some local drug that would interrupt the nerve pathway to generate from the periphery to the central nervous system the sense of pain, I may indeed introduce some of that medicine at a level that would anesthetize about this region, but nothing higher, because I wouldn't want to necessarily block the ability to breathe. So, for example, if T6 is that area that is responsible for the bottom of the sternum, I definitely would want to be below that. So again, T10, spinal nerve root, proximal level of the abdomen. So when a woman's going to have a cesarean section, for example, and they're going to actually be blocking that region where they're going to be doing the surgery, which is right here, they're going to want to be able to introduce a catheter here, actually about L4, right about here, and they're going to then inject enough medicine that everything from this point down will be anesthetized and paralyzed. Which means that when you've had a spinal anesthesia, indeed, you may not be able to move the lower extremities, but you should still be able to breathe and move your arms. And they can, so they can be awake for their cesarean section. Okay, now if we look at this particular crosscut of the spinal cord, I just want to introduce you to some of the terminologies that you may be seeing in your text. You have a ventral or anterior root of this nerve pathway. You have, this is actually white and gray matter of the, and it's reversed actually in this pictorial, but nonetheless, of the central nervous system portion of the spinal cord. In the simple reflexive arc, you actually might get an impulse that will stimulate coming into the dorsal root ganglion, synapsing right here in this portion of our central nervous system in the spinal cord, with one little, right here, this word interneuron, with one little connection between this synapse and the effector side. You'll have an instantaneous response of contraction and withdrawal, for example, of either your foot or you have a patellar reflex that can be elicited. There is not a, in a simple reflex, you do not have a generated number of impulses going up to the brain and then back down from the brain to make the decision to make that movement. In a simple reflex, you have receptor, you have a simple synaptic junction between that and the interneuron, and then you have an effector response. So this is the axon of the motor neuron, the one that's going to actually affect contraction of these muscles and cause them to withdraw. And then you have the sensory neuron, and this is the dendrite, or the axon of the sensory neuron. I think both there as well as in your textbook, they kind of describe that simplistic reflexive movement. And most importantly, the fact that it does not go up to the brain to then get additional impulse. So I do want you to be familiar with the simple reflex, and that pictorial shows it about the best way. I would also like you to draw your own version of that. The words that you should be familiar with would be the sensory neuron, the interneuron, and the effector or motor neuron response. At this point, we're going to take a little break, and I'm going to end the show at this point and reintroduce the sympathetic nervous system along with neurotransmitter function in our next audio. Any questions? Be sure to email me, read through the chapter, use your online resources, and do continue to try to stay on time for the completion of your modular exams. Again, the next one will be on sympathetic and parasympathetic divisions of our autonomic nervous system, and I'm going to separate those out.